Hi, this is Jocelyn Compton, and in this section we'll cover respiratory pharmacology. This section will go faster than the other talks we had with respiratory physiology and pathology. Histamine is an organic nitrogen compound that is classically involved in the allergic inflammatory response. The H1 blockers are reversible inhibitors of the H1 histamine receptor and are generally used in the treatment of allergies. There are two generations of histamine blockers, and they can be remembered based on their sedating properties. Remember that the newer second-generation histamine blockers are typically less sedating. First-generation histamine blockers include diphenhydramine and chlorpheniramine. When are they prescribed? These drugs are used to treat allergies, allergic rhinitis, acute urticaria or hives, and motion sickness, and they can be used for sleep as well. Side effects, besides sedation, include what classic antimuscarinic side effects? Well, urinary retention, dry mouth, blurry vision, and delirium, among others, and anti-alpha adrenergic effects like hypotension and dizziness. So, these drugs should be used with caution in older folks. Second-generation antihistamines include loratadine, fexofenadine, desloratadine, and cetirizine. Like the first-generation antihistamines, they can be used to treat allergies and also chronic hives. Why do these drugs have less sedation than first-generation antihistamines? Because they have less penetration into the central nervous system. Flash quiz. Which H1 blocker is more likely to result in sedation? Chlorpheniramine or fexofenadine? Chlorpheniramine is a first-generation H1 blocker, and thus would be more sedating. Always consider this difference when prescribing to the elderly. Alright, a quick word about expectorants, as this is just moderately high yield. The idea here is to clear the bronchiole of mucus. Guaifenazine is an expectorant that thins secretions. It has no suppression of the cough reflex, as do preparations containing codeine. So how can you remember this drug? The root of the word kind of sounds like fenestrate, which, if you think about it, guaifenazine is poking holes in secretions to thin it out. N-acetylcysteine is an inhaled mucolytic that is used in cystic fibrosis, COPD, chronic bronchitis, and other chronic bronchopulmonary conditions with significant mucus production. Do you remember what other indication it has? Recall from your musculoskeletal pharm talk that this is the same agent used to treat acetaminophen overdose. Yeah, so cough and cold medicines are board testable. Dextromethorphan is a cough suppressant related to opioids. How does it work? It blocks the N-methyl-D-aspartate receptor, which is a calcium ion channel that's critical in memory and learning. Theoretically, in normal doses, it reduces coughing from minor throat and bronchial irritation. It has some abuse potential because it can cause dissociative hallucinations at high doses. Flash quiz. What's the mechanism of action of guaifenazine? It thins secretions. Pseudoephedrine and phenylephrine are also commonly used in cold and allergy. They're used as OTC drugs for nasal decongestion. They basically act as alpha-adrenergic vasoconstrictors, so you get less nasal tissue swelling and congestion. In addition to hypertension, tachycardia, palpitation, and stimulant side effects, what else do you have to worry about? Recreational drug abuse, since pseudoephedrine, but not phenylephrine, can easily be reduced to methamphetamine in a meth lab. There are numerous classes of medications to treat asthma, which truly could be a series of lectures in and of itself. However, understanding the basic underlying pathology involved in asthma exacerbations, as well as the mechanisms of the various drugs used to prevent and treat asthma, should make remembering these medications easier. What is bronchoconstriction mediated by? Inflammation and parasympathetic tone. Therefore, some asthma medications target each of these pathways. Let's start with the parasympathetic pathways. This pathway is going to help you a lot when you think of some of the asthma drugs. What mediates ATP conversion to cyclic AMP? Adenylyl cyclase, or AC. And what mediates cyclic AMP conversion to AMP? Phosphodiesterase, or PDE. Beta-2 agonists relax bronchial smooth muscles. Ultimately, it increases cyclic AMP levels. It also lowers intracellular calcium levels and causes smooth muscle relaxation and bronchodilation. Go back to the musculoskeletal section for a complete review of smooth muscle contraction and relaxation if you're feeling a little rusty. For acute attacks, albuterol is a good beta-2 agonist to start with. Long-acting beta-2 agonists, or LABAs like salmeterol and formoterol, have the same mechanism of action but last longer, so they're used with a steroid in combination with an inhaler for asthma control. When could you use LABAs alone? LABAs can be used by themselves in diseases with less inflammation, such as COPD. Theophylline is a methylxanthine that is used to treat both asthma and COPD. The mechanism of action is likely due to its inhibition of phosphodiesterase. Thus, you get decreased breakdown of cyclic AMP and then bronchodilation. Do you see how CAMP is really the key to smooth muscle relaxation? Beta-2 agonists increase it by increasing production, and theophylline increases it by decreasing utilization. So, what are the downsides of theophylline? For one, it has a narrow therapeutic index, and it has some nasty side effects including nausea, vomiting, arrhythmias, and seizure. It's also metabolized in the liver by cytochrome P450, and therefore it interacts with a number of drugs like cimetidine and phenytoin. Theophylline and methylxanthines, like caffeine, can block adenosine, since they bind at the adenosine receptor as non-selective antagonists. What's the clinical consequence? If you are using adenosine to break a tachyarrhythmia and your patient is on theophylline, it may not work unless you up the dose. So because of these headaches, we don't use theophylline as much anymore, but they sure make great board questions. Ipratropium competitively blocks muscarinic receptors and is used to treat COPD and asthma. Tiotropium is a newer, long-acting muscarinic receptor antagonist for COPD, and it mainly binds with the M3 muscarinic receptor. Okay, let's move on to the other pathway of asthma, inflammation. Inhaled steroids like beclomethasone and fluticasone are first-line therapy for persistent asthma, especially when patients experience asthma symptoms more than a few times each week. They work by damping the production of all cytokines, especially NF-kappa beta. Oral steroids like prednisone are used to treat acute exacerbations that are not reversed with short-acting beta agonists. What are the long-term side effects of chronic steroid use? If you don't know the answer, you can pause this talk and check out Cushing's syndrome in the endocrine lecture. Then, there are the anti-leukotrienes. Xyleutin inhibits the 5-lipoxygenase pathway. Is this upstream or downstream from the leukotrienes? As you'll recall from the musculoskeletal pharma section, xyleutin is upstream, preventing the formation of leukotriene C4, then D4, and finally E4. These are the products that are thought to be responsible for allergic inflammation, bronchoconstriction, and mucus production. Similarly, montelukast and zafarlukast, which is used less commonly, interfere with the action of leukotrienes C4, D4, and E4 by blocking their binding to what receptor? That's right, cysteinoleucotriene receptor 1. Can you think of one special indication for the anti-leukotrienes? That's right, treatment of aspirin-induced asthma. Finally, there is omalizumab. So what is it and how does it work? This is a monoclonal IgG antibody against IgE. It binds up serum IgE so that it can't bind to Fc receptors on which cells? On mast cells and basophils. Therefore, the IgE can't bind antigen and cross-link to cause mast cell and basophil degranulation. It's used in patients with moderate to severe persistent allergic asthma who failed treatment with inhaled steroids and long-acting beta agonists. Here's a summary slide to help you keep the asthma drugs straight. Pause here and make sure you recognize each of these drugs. Flash quiz. When are LABAs used alone? In COPD. Methacholine is an acetylcholine analog with a non-selective muscarinic receptor agonist. It really has no practical therapeutic application. Instead, we use inhaled methacholine to diagnose bronchial hyperresponsiveness, which we see in asthma and to a lesser extent in COPD. If the FEV1 drops by 20% or more with an inhaled methacholine concentration of 4 mg per ml or less, then that is considered a positive test for airway hyperreactivity. Here is a methacholine challenge for a 63-year-old white female non-smoker with shortness of breath. On the x-axis, you can see the methacholine dosing concentration. You can see that her FEV1 clearly drops by greater than 20% from baseline when she reaches 1 mg per ml. So this is a positive test. So how are the results of a methacholine bronchial challenge test helpful? Well, this test is pretty sensitive. Remember the mnemonic SNOUT from the biostats lecture? So if it's sensitive, then the test rules out. With a negative test, it will essentially rule out asthma as a diagnosis. But this test isn't very specific. The mnemonic SPIN helps us remember that specific tests rule in diseases. So here, if this test is positive, then it might help you make the diagnosis of asthma with the right clinical context. But you have to worry about false positives because other conditions can give you a positive test, like smoking, URIs, allergic rhinitis, and GERD. Finally, we have bosentan, which can be used to treat pulmonary arterial hypertension. How does it work? It is a competitive antagonist of endothelin-1 receptors, which decreases the overall pulmonary vascular resistance. Let's do a few board-like questions on the material in this chapter. A premature newborn is brought to the clinic because he is having difficulty breathing. Physical examination reveals that he is breathing rapidly and has intercostal retractions, nasal flaring, and cyanosis. The physician administers an agent intratracheally to treat the neonate's condition. Which of the following is the dominant component of this substance? A. Phosphatidylcholine. B. Sphingomyelin. C. Phosphatidyllinositol. D. Phosphatidylglycerol. Or D. Phosphatidylethanolamine. The answer is A. Phosphatidylcholine, also known as lecithin. It is the dominant component of pulmonary surfactant. Pulmonary surfactant consists of phospholipids, 85%, proteins, 10%, and neutral lipids at 5%. About 75% of the phospholipids in surfactant are comprised of phosphatidylcholine. The role of surfactant is to keep the alveoli from collapsing. It is not produced in adequate amounts until around the 36th week of gestation. Thus, premature infants are at risk for neonatal respiratory distress syndrome. If delivery can be delayed, the mother can be given glucocorticoids, which can help induce production of the surfactant in the fetus. A 29-year-old woman with a long-standing history of asthma and eczema presents with watery, itchy eyes and stuffy nose of 3 days' duration. The woman states that she has had similar symptoms before, usually during the spring. Her heart rate is 82 beats per minute, blood pressure is 117/80, respiratory rate is 14 breaths per minute, and oxygen saturation is 96%. This patient's symptoms are due to the activation of which of the following receptors? A. Histamine 2, B. Histamine 1, C. Alpha 1, D. Beta 1, or E. Beta 2. The answer is B. The patient's symptoms are consistent with those of seasonal allergies. The patient has a history of asthma, eczema, and allergies, and most likely suffers from atopy. Seasonal allergies are a result of histamine 1 receptor activation, which results in pruritus, bronchoconstriction, and increased nasal and bronchial mucus production. Seasonal allergy symptoms can be treated with antihistamines, such as loratadine, which are histamine 1 antagonists. A 25-year-old woman with a history of asthma is brought to the emergency department by EMS after ingesting a full bottle of theophylline in a suicide attempt. At presentation, she is having a tonic-clonic seizure, is hypotensive to 80/40, is tachycardic to 160 beats per minute, and is tachypnic to 30 breaths a minute. The EMS personnel report that she has been seizing for the last 15 minutes. What is the mechanism of action of the most appropriate drug to counteract her intoxication? A. Inhibiting the sodium-potassium 2-chloride cotransporter. B. Decreasing intracellular cAMP. C. Inhibiting the sodium-potassium ATPase pump. D. Increasing intracellular cAMP through beta-2 adrenergic receptors. Or E. Increasing intracellular cAMP through non-selective adrenergic receptors. The answer is B. The drug theophylline is a phosphodiesterase inhibitor that leads to the decreased hydrolysis of cAMP to adenosine monophosphate. An overdose of theophylline will therefore result in an elevated intracellular level of cAMP. Beta blockers such as metoprolol may therefore be given to reduce cAMP levels through inactivation of adenylate cyclase. A cardioselective beta blocker must be used in cases of asthma to avoid inducing bronchial hyperreactivity. A 57-year-old man with a history of chronic obstructive pulmonary disease and heavy cigarette use presents to the emergency department with several hours of breathlessness. He states that he feels as if he is unable to exhale completely and therefore must take a subsequent deeper breath. A simple spirometry test is ordered. In this patient's presentation, which of the following letter choices would be pathologically increased in volume? D. Choice D represents the residual volume, which is the volume that remains in the lungs after maximal expiration. The residual volume increases dramatically in emphysema, especially in the condition of air trapping, in which it is difficult to exhale completely. A 50-year-old man with a history of heavy smoking presents to his physician with complaints of increasing shortness of breath over the past few months. On physical exam, he appears barrel-chested and dyspneic. He is tachycardic and has hyperresonant lungs with decreased breath sounds. There is no evidence of hepatomegaly or liver nodules on palpation, and no evidence of scleral icterus or jaundice. Which of the following is the most likely diagnosis? A. Bronchiectasis. B. Asthma. C. Centroacinar emphysema. D. Panacinar emphysema. Or E. Alpha-1 antitrypsin deficiency. The answer is C. The patient presents as a classic pink puffer, making emphysema the most likely diagnosis. Because smoking is closely linked to centroacinar emphysema, this is the best answer choice. The STEM mentions the absence of jaundice and liver problems, making alpha-1 antitrypsin deficiency and the associated panacinar emphysema unlikely. A 24-year-old man who has smoked 1.5 packs per day for the past 6 years comes to the local emergency room complaining of sudden onset of unilateral pleuritic chest pain and shortness of breath. He is tall and thin. He has no personal or family history of medical illnesses and denies trauma prior to the onset of his pain. On examination, he is tachypnic and has decreased breath sounds at the right upper zone of the lung. Which of the following additional physical findings is likely to be present? A. Hyperresonance on percussion. B. Increased tactile fremitus. C. Tracheal deviation away from the affected lung. D. Bronchial breath sounds. Or E. Bilateral chest expansion. The answer is A. Dyspnea and unilateral pleuritic chest pain in a young male smoker are highly suggestive of spontaneous pneumothorax. Risk factors include male sex, smoking, and a tall, thin stature. Because air is filling up the space previously occupied by the lung, there will be hyperresonance on percussion on the side with the lesion. Why not C? Tension pneumothorax will have tracheal deviation away from the side with the lesion. In spontaneous pneumothorax, there may or may not be any tracheal deviation. If it is present, a contralateral shift of the mediastinum will be seen on chest X-ray.